to this webinar that we're recording to be hosted on the North East and North Cumbria website for congenital heart disease. It's my pleasure to introduce Dr. Helen Oxenham, who is an adult consultant cardiologist at North Tees Hospital, and she has a special interest in congenital heart disease. She's here today to talk around what the adult cardiologist needs to know about congenital heart disease. So over to you, Helen, and thank you.
Thank you, Kaye. Yes, so I'm just going to talk about some adult congenital heart disease that is the most simple type and the kind of thing that you might be expected to look after these patients in a district general hospital rather than a specialist setting. So why are we talking about this? Well, most people with congenital heart disease now live until they are adult, and the period of time that people are adults is much greater than the period of time that they're children, and so adult congenital heart disease makes up the largest proportion of congenital heart disease patients in the UK, and especially people with mild abnormalities, they will live throughout their life, and during that lifetime we need to know about them because they'll have specific issues to do with heart rhythms and pregnancy and heart failure, that kind of thing. So being able to know about these more simple types of adult congenital heart disease is a useful thing so that we can provide that kind of care and expertise closer to where the patients are living. And if you think about it, we already look after people with congenital heart disease because we already routinely, as an adult cardiologist, look after people with bicuspid aortic valve. And in many ways, bicuspid aortic valves, there's a greater incidence of things happening, requirement for intervention and expertise than there are for some of the lesions that I'm going to talk through. So it makes sense that we would also look after these patients too. So just to talk about the network, the North East and North Cumbria Congenital Heart Disease Network, which covers both paediatric and adult. The level 1 centre is the centre at the Freeman Hospital, and that's where all the complex adult congenital and paediatric congenital hearts care is done, and that's where the surgery happens, percutaneous interventions, advanced heart failure, etc. And at the moment, they also look after a lot of people for their ongoing follow-up, even if they only have more simple lesions. We don't have a level 2 centre within the North East at the moment. And level 3 centres are defined as places where there might be an adult cardiologist, someone like myself, who does a joint clinic with a specialist from the Freeman and who looks after people with much less complex lesions. It's also possible to see these patients in clinics without a specialist from the Freeman Hospital as well. So at the moment, the people who are involved in the network include consultants who look after paediatric, neonatal and fetal problems, and consultants who look after patients in their adult life. So the adult congenital heart disease specialists at the Freeman include Dr. Coates, Dr. Jansen and Dr. Rebecca. And in the region, there's one person in each trust who has an interest in adult congenital heart disease, and they are listed. A PEC is a paediatrician with expertise in cardiology, and they are also working in the district general hospitals as listed. And the whole aim, both for our network and also the government's current aim, is to bring care closer to home for all patients where possible. So according to our level 3 centre, the Freeman, they are happy for us in our district general hospitals to look after this list of patients. So they're people who've had atrial septal defects that are repaired or are unrepaired but small, people who've had a PFO closed, isolated small VSDs, repaired ventricular septal defects, patent ductus arteriosus, and also obviously aortic and mitral valve disease. That would be the bicuspid aortic valves, and mild pulmonary disease as well. I'll just go through some of the different conditions one by one to give some examples of what we need to look for and how we look after these patients. So an atrial septal defect is common. It's about 10 to 20% of all adult congenital heart disease. And it's often identified by chance on an echo or MRI. Often a chest X-ray can show up an abnormality, and this chest X-ray shows the classical bulge in the pulmonary area, and that's a sign that there may well be an ASD present. If we have found an ASD or what we think might be an ASD, the next step is to do an echo assessment, both with transthoracic but then transesophageal echo. And we have to measure the size of the hole in lots of different planes. And we're looking to see if there's an adequate rim of tissue around the hole. So we're looking this view, there's the superior vena cava, so this is the superior rim, and the view on the left, there's the round circle is the aorta, and there's a little bit of rim near the aorta. And you need to see whether there's enough tissue in all areas. It's not so much of a problem if there's not adequate rim of tissue at the aorta. The other things to look for is, are there more than one hole? That's called a fenestrated intraatrial septum, and whether there are other abnormalities present, like do they have abnormal pulmonary venous drainage? And when you do a transesophageal echo, you follow the normal standard protocol, getting all the views and looking for all of the 4 veins as well to see if they're present. But if you can't see them, and that's sometimes difficult on TOE, then a CT scan can be, or an MRI scan can be used to look for pulmonary veins. The presence of left ventricular impairment is also important because that will affect decision making. So these are some images just showing the different views and the rims of the aortic valve. So there's the aortic valve here with the aortic rim and the posterior rim. And then in the 4-chamber view, there's the posterior ring. And in this view on the right-hand side, the long axis view, there's an inferior and superior rim. And that's the kind of thing we would be able to do in most of our practices. The sinus venosus defect is when the pulmonary vein, it's usually the right upper pulmonary vein, instead of it going into the left atrium, it drains into the SVC and then the right atrium. So this is some still pictures of an example of that, and where the Doppler signal in the pulmonary vein is upside down to what you'd expect because the flow is going the other way. So with these kind of problems, CT scanning is also extremely helpful and can define the anatomy of where the hole is and where the pulmonary veins are very well, and can be used if you're not sure whether you've been able to see all the pulmonary veins. But if you don't feel able to, or you don't have access to good cardiac CT or cardiac MRI in your trust, then that's a kind of scan that could be also done at the Freeman Hospital if necessary. When someone has an ASD, an MRI scan is also very helpful, and the scan on the left-hand side of this picture shows an MRI scan with an ASD. It's not so good just to look at the size of the hole, but it's particularly good at measuring whether there's right ventricular volume enlargement, because that's really important to know whether the hole has to be closed. And it can show where the pulmonary veins are. On the right-hand side of this picture, there is an image of someone who's had an ASD closed, and it just shows how useful CT scanning is in assessing these patients. This lady had a surgical ASD repair. This is where the repair is with the bright white of the patch that was put in, but they have left an inferior defect. So it's a very rare inferior defect that's visible on the CT scan. So one of the most common questions that comes up is this an ASD or a PFO? And the main thing to look for is right heart dilatation present? So when people are adults, by the time they're adults, particularly if they're over 50, they've had that defect there for 50 years. If there's a significant shunt present, then the right heart will be dilated. And if there isn't a significant shunt, then the right heart won't be dilated. So one thing to do if you're trying to work out if there's an ASD or a PFO is to look for right heart dilatation, and an MRI scan is really helpful in that situation. If the shunt is less than 1.5 to 1, it would suggest that the shunt isn't significant and it's more likely to be a PFO than an ASD. People have looked at the incidence of PFOs with age, and PFOs are very common. And one of the things we sometimes see is we may get an echo in an 80-year-old. They've got very dilated, stretched atria. And then there's this question, is there an ASD? And quite often that's likely to be a PFO that's become stretched, and so it's opened a little bit more. And those patients often don't have significant right heart dilatation, but the colour going across the intra-atrial septum is likely to represent a PFO that was already there, but it's got slightly enlarged with the atrial enlargement in later life. The other thing you can do is, again, you can use cardiac CT to help you decide whether this is an ASD or a PFO. And if it's an ASD, there's a proper hole with contrast that can go horizontally into the right atrium, whereas if it's a PFO, you don't see an actual hole so much, or if you do, the flow is only transient. And again, with echo, you can have a look at the colour flow across the intra-atrial septum. If it's there constantly throughout diastole and systole, then it's an ASD. If it's there only transiently, it's much more likely to be a PFO. But again, looking for right heart dilatation is really essential. And indications for closure for the ASD, these are the ESC guidelines. The main indication is the right ventricular volume overload. So if there's right ventricular volume overload without pulmonary hypertension, they can be referred for closure. If there is pulmonary hypertension, or if the left heart is impaired, it's a bit more difficult, but that side of things can all be done by the level 1 centre. So for us, that would be the Freeman, where they would do some more complex tests to work out if the patient should have the ASD closed or a fenestrated device put in, that kind of thing. These are the kind of devices that are used, and device closure has become first choice for closure. You can close anything up to a stretched diameter of 38 millimeters as long as there's sufficient room. And about 80% of patients will get a percutaneous closure for their ASD. It's very successful, and there's very few complications, and late complications are also extremely rare. Up to now, our level 1 centre has tended to continue to follow ASD patients up even after closure. But one of the things we're looking at is whether we can take that work from the Freeman so that we can follow these patients up more locally, because they've got such a low risk of things happening. They really just need an echo and an ECG about every 2 or 3 years. And the these graphs show the prevalence of atrial fibrillation. If your ASD is closed under the age of 40, you've got a much lower risk of having atrial fibrillation than if it's closed over the age of 40. But there is still a chance that you can get things happening later in life, and those things tend to be episodes of atrial fibrillation. So most of the studies that are available looking at ASD closure, they follow people up for about 8 or 9 years, but there aren't very many people who've followed people up for longer than that. However, this graph just shows that we are tending now to close ASDs percutaneously rather than surgically. And both do have a similar outcome, but obviously risk is higher if you have surgical closure. And most complications happen within the first year post-procedure. So this is one study which did look at people who'd had an ASD repaired as children, and they then looked at them 45 years later. And although all the other studies in the literature suggest that people have got a very low risk of anything bad happening over a sort of 10-year period, if you do follow people up into their 50s and 60s, then people do start getting mainly atrial fibrillation. So about 20% of these patients were in atrial fibrillation once they got to the age of about 50 or 60. So I think there is a reason to keep an eye on people like this, but the type of thing to look out for could be picked up by an ECG as much as an echocardiogram, for example. So that's why at the moment, the people who make the devices ask for these patients to continue to be followed up. But exactly how and who should be doing that is what we're sort of questioning, and whether the ECG and echo can be done closer to home. Oh, sorry, I have managed to end the show. And this slide just shows that people with ASDs, whether they've been repaired, whether they were secundum or not, are much more likely to get atrial arrhythmias rather than ventricular arrhythmias compared to other people with adult congenital heart disease. So when do you not intervene in people with an ASD? Well, actually, in my practice, I would send everyone to our level 1 centre for them to make that decision. I don't think that's necessarily my role. My role is to identify the patients and to do the tests to prove that they have the condition and to look for other things that are wrong with them. But when they are in atrial fibrillation, for example, they may need to have that treated first before a device is put across the intraatrial septum, because that can make ablations more difficult afterwards. Or if they've been picked up because they've had an echo due to LV impairment, then those patients need to be much more carefully evaluated, and they don't automatically get an ASD closure. And again, people with pulmonary hypertension, they may not benefit from ASD closure. What about a PFO? So at the moment in the UK, the reasons to consider closure of a PFO is if you've had an unequivocal and unexplained systemic embolism. Usually it's a stroke without any evidence of significant arrhythmias on 24-hour tapes, etc., and no other cause for that. And you need to document a PFO. Usually you do this with a bubble study and then a transesophageal echo to show that there is bubbles crossing the intraatrial septum, either with or without Valsalva, and also the transesophageal echo to just look at the actual anatomy of the PFO. So that can all be done locally. And then this illustration shows exactly where the device is put to close the PFO. And again, very similar to the ASD, close your patients. Follow-up shows that it's very rare to have any late embolization or thrombosis or other problems. So those patients, I'll just maybe go back. So for these patients, PFO post-closure patients, in our practice, we would follow them up in a similar way to the ASD closure patients, which would be to have an ECG and an echo approximately every 3 years. And that's to look for right heart impairment or pulmonary hypertension developing or atrial arrhythmias. Okay, so that's ASDs and PFOs. The next simple abnormalities that we follow up as in adult congenital heart disease would be the VSDs. So ventricular septal defects that occur and are still persistent in adulthood tend not to be the muscular ones. The muscular ones are often seen in pediatric practice and they usually close spontaneously, whereas the perimembranous or subarterial or inlet ones are the ones that tend to hang around and they're still there in adulthood, and they're the ones that we often get referred to be assessed. And the current guidelines would suggest that we need to look for two main things. The main one is symptoms, and that would be like breathlessness on exertion, and the other one is left ventricular enlargement. So if there is no breathlessness and no left ventricular enlargement, then we just need to follow them up every 3 to 5 years with an echo and ECG. The other thing that can happen with people with a VSD, if you see in this picture here, it's very close to the aortic valve, and the blood flowing through the VSD can sometimes cause turbulence, and so that can cause some problems with the aortic valve. So aortic regurgitation can occur if someone's got a perimembranous VSD. And so progressive aortic regurgitation or endocarditis of the aortic valve would be another reason to consider closing the VSD. So left ventricular enlargement with symptoms or progressive aortic regurgitation or endocarditis are the two reasons to consider closure for a VSD. And in my experience, that almost never happens. It's extremely rare to see left ventricular enlargement with someone with a small VSD. Usually all the big VSDs have already been closed by the time people get to adulthood. So they have a good long-term survival and maybe they have slightly more atrial arrhythmias. If you compare repaired versus unrepaired VSDs in this study, it looks like it's worse if you've had your VSD repaired. But if you look at the in the graph, the actual numbers only go from 80% to 100. So these are very small differences in all the different populations over 40 years. If someone's already had a VSD repaired, then what we need to do is just review them every 2 to 5 years with an echo and an ECG, as long as they stay asymptomatic. And that can be done in an echo-led clinic rather than always seeing a consultant, for example. This patient is someone who was known to have a small perimembranous VSD. He'd been discharged at the age of 16 from follow-up. and his echo showed that he did have a perimembranous VSD with a left to right shunt, but he also had left ventricular dilatation. So is this someone who needed to have his VSD closed? The complicating factor was that he was also a triathlete, and athletes can also get left ventricular dilatation. So we did an MRI scan to measure the shunt across the VSD to see whether the LV dilatation was due to the VSD or was it due to his athletic training. And sure enough, it was due to his athletic training because the shunt wasn't big enough. In that situation, what you could do is ask the person to stop training and then to reassess the left ventricle to show that the left ventricle can get smaller again. But in my experiences, I've never sent anyone for VSD closure who's been known to have a VSD in adulthood. So pulmonary stenosis is the other simple congenital abnormality that we can also follow up in a district general hospital. It's got a very good prognosis, about the same as the general population. And in mild pulmonary stenosis, you only need to do an echo about every 5 years. It's commonly seen in a condition called Noonan syndrome, and Noonan syndrome has all sorts of different features associated with it, but sometimes people can look very, very normal, and otherwise, and at other times they have other problems. The other causes of pulmonary stenosis include intravenous drug use. Pregnancy is tolerated very well. We would normally just do an echo in the second trimester for people with known pulmonary stenosis, just to make sure the right heart is coping. And we just measure the severity in the same way, similar numbers to aortic stenosis, and only intervene if the peak gradient is above 50 millimeters of mercury with symptoms. But again, once people start getting more severe pulmonary stenosis, that would be the time where you might want to refer the patient to the level 1 centre for consideration of treatment. Treatment can be with a balloon stretch of the pulmonary valve, and this shows really good outcomes. And then, of course, there are the people who've previously had a pulmonary valvuloplasty, often as a child, who are then adults, and we then follow those people up. And they have very good outcomes and rarely develop significant abnormalities in later life. What we're looking for is development of pulmonary regurgitation. So pulmonary regurgitation in an adult is usually seen after a previous pulmonary valvuloplasty. There is another group of people who have pulmonary regurgitation and they have bad lung disease or pulmonary hypertension, and they wouldn't really be part of the adult congenital clinic. So if people have got pulmonary regurgitation, again, we just follow them up with occasional echoes and assess their symptoms and look for right ventricular volume overload. This is a young woman who was seen in casualty with some chest pain, and she had this chest x-ray, and her echo shows she has got severe pulmonary regurgitation. She did actually have a pulmonary valvuloplasty as a child, but then was lost to follow-up. The chest x-ray was actually then referred to the lung specialists because they thought there might be a lung cancer, but very sensibly the lung specialist had already seen that we'd done an echo and were reviewing her, so they were able to cancel that side of things. And the treatment of pulmonary regurgitation, if it is severe and causing symptoms, would be to replace the valve, and that can sometimes be done percutaneously, like this percutaneous valve here, as long as there's an appropriate place to put the pulmonary valve replacement. But occasionally it's done surgically. Again, those decisions aren't ones that we have to make. We just need to identify that severe pulmonary regurgitation is present and then refer to our level 1 centre. Adult congenital heart disease, obviously genetics are important, and people who are pregnant, who themselves have adult congenital heart disease, do have a slightly increased risk of offspring with adult congenital heart disease also, but the risk isn't all that high. Obviously, somebody who has Marfan's has got 50% risk of their child having Marfan's, but for things like an ASD, it's only between 4 and 6% if it's a woman who's had the ASD, or if the father of the child had the ASD, the risk is only between 1.5 and 3.5%. So not all patients require fetal echo assessment of their babies or child screening, but it can be considered. So what this talk really is to try and encourage people to feel confident to look after patients who have got simple adult congenital heart disease. We are already looking after people with bicuspid aortic valve, and if you compare the rates of morbidity and mortality in people with bicuspid valve disease versus something like a VSD, for example, there's a big difference. There's a far higher incidence of things happening in people with bicuspid valves compared to VSDs, and so it makes sense that we should be able to look after these people out with the level 1 centre. Why do we want to encourage you to do this? Well, it's better for patients. They are a low-risk group of people. They do tend to have fewer morbidities and things wrong with them than a lot of our patients do in our general clinics. And that is just very interesting as well. But we do also recognise that we do need to be able to have robust pathways so that we know exactly when to refer into the level 1 centre, and also we do need to get some additional training for the cardiac physiologists. And there's also sometimes a reluctance because who's going to pay for all of this work? So that also needs to be clarified. And that's it.
Thank you so much for that, Helen. Really brilliant talk. Any questions, get involved directly with the network. The email is on the network website.